Hi, good morning, everyone. It's great to be here with you all. This is my first academic conference presentation ever, so please go easy on me. Thank you. My name is Lilian Ha. I am presenting today on behalf of my co-investigators and mentors, aka my bosses, Drs. Angela Aidala and Michael Yomagita. So for this presentation, I'm going to pivot a bit from the clinical to discuss some more of the contextual dimensions of frailty and aging among people with HIV, particularly among older women with HIV. So I want to start by briefly justifying our focus on older women with HIV as a distinct population of interest. So we know sex and gender differences in biologic and sociobehavioral factors uniquely contribute to the experience of aging with HIV. Studies on quality of life measures among aging folks with HIV also indicate that older women often report lower quality of life scores. And still, there is a kind of distinct lack of empirical studies focusing on older women with HIV as a unique service population, and not only their overall mental and physical health, but also their experiences with stigma, isolation, social support, and service needs and utilization. So we wanted to leverage data we have from a community-based cohort study of people living with HIV in New York to paint a holistic picture of the functional health profile and aging-related needs and concerns of older women with HIV. So CHAIN is a cohort study that has been a major source of service planning data for New York since the 90s. And we collect information by speaking directly with people with HIV through comprehensive in-person interviews conducted in homes and agency settings with a community-based interviewing team, many of whom are themselves people with HIV. And topics on our questionnaire include HIV care continuum outcomes, comorbidities, life outlooks and perspectives, service needs and utilization. And so the data I'll be presenting on comes from our most recent rounds of interviews from 2015 through 2021 from respondents in New York City and the Tri-County region, which is a slightly more suburban area north of New York City. So we looked at 4 key measures of healthy aging, mental health functioning and physical health functioning, which are based on a standard short-form survey developed by the Medical Outcomes Study. We then measured respondents' frailty index based on multiple domains of cognitive health, general health status, functional independence, social support, medication use, and depressed mood. And then as a composite binary indicator of healthy aging, we also report on positive thriving, which is based on positive physical and mental health functioning, as well as having a low frailty index score. So very quickly, our sample of older women with HIV is predominantly Black and Latina. Over half live under the federal poverty threshold, and about half report living alone at the time of interview. So just to start, almost all respondents, women over the age of 50 in New York City, and about 3/4 of those in Tri-County reported at least one comorbidity associated with increased mortality risk among people with HIV. We've also shown the statistics, the comorbidities for women in our sample under 50 here to show kind of the increase. Also of note, the mean number of comorbidities was slightly higher among women, older women in our sample compared to respondents over 50 overall. So the mean number of comorbidities for men over 50 in our sample, I believe, was 3. So here we have an overview of the prevalence of certain comorbidities, with the orange arrow indicating comorbidities where the prevalence is higher among older women in our sample relative to the overall sample. So, for example, for asthma, chronic respiratory diseases, diabetes, chronic sinusitis, and arthritis. And so here I just want to take a second to highlight some qualitative responses from our participants when asked to describe their biggest health concern. At the present moment, respondents most commonly described one or more comorbidities as their primary concern. So for example, one respondent mentions pain in the stomach and feet, motor function, forgetfulness. Another respondent also brings up chronic pain, diabetes. Moving on to measures of physical health functioning, we see that mobility is a concern. Compared to our overall sample of older people with HIV, women have higher rates of being limited in moderate activities, such as moving a table, carrying groceries, and climbing several flights of stairs. Bodily pain is also a highly cited concern, with half of older women reporting that pain interfered with their ability to do normal work outside of the home. Women also reported slightly lower rates of reporting being a happy person, being calm and peaceful most or all of the time. About half of older women in our sample were characterized as having less than adequate mental health functioning based on a summary score. So, as previously mentioned, our measure of frailty takes into account cognition, social support, and medication use. So in addition to having higher rates of being limited in climbing stairs and moderate activities, women had higher rates of polypharmacy. And while older women less often reported living alone compared to older men in our sample, about 1 in 4 reported less than 3 family members or close friends who were aware of their HIV status. So based on these measures, 38% of older women in our sample were characterized as having a high frailty score, and only 5% could be characterized as thriving. So in a regression analysis, years living with HIV, identifying as Black or Latina, living below poverty threshold, perceived stress score, and comorbidities were all associated with low physical health functioning. Perceived stress score also predicts low mental health functioning while living in Tri-County as opposed to New York City, and receiving care that meets good practice standards protect against low mental health functioning. Perceived stress score, current problem substance use, and comorbidities also all significantly predict a high frailty index score. So to wrap up, I'm briefly also going to touch on reported service needs and utilization among older women on our sample. So the orange bar represents service need, and the blue bar represents service utilization as reported by receipt of services. And so what's visible in the orange represents kind of a gap, a service gap. The highest need across both New York City and Tri-County was for financial assistance, followed by need for mental health and social services case management. Nearly half of older women in our sample had not used women's health services in the past year. And looking again at service gaps, we see most older women who need medical case management and alcohol or drug services do not receive them. Also of note, only half of respondents reported that during a visit for HIV care or services in the past year, someone asked them questions related to their mental health and emotional well-being. So to summarize, we found that nearly all older women with HIV experience comorbidities that are often their most pressing health concern. Women experience higher rates of chronic respiratory diseases, diabetes, chronic sinusitis, and arthritis. We also found that number of comorbidities and perceived life stress strongly predict low functional health and high frailty. And so we recommend holistic approaches to promote healthy aging that prioritize screening and prevention of multimorbidity, integrate assessment of traditional and HIV-related factors, and consider sociobiological influences of sex and gender. Future studies, we hope, will also evaluate optimal timing to commence aging-related comorbidity risk assessment and intervention, which likely differs by sex and gender, HIV serostatus, and other social determinants of health. Previous network analysis of data from our study also found that service linkages with primary care, dental practitioners, case management, and housing services are all associated with higher odds of adherent ART use and viral suppression. So these findings are consistent with the growing awareness of the benefits of service integration and coordination of care to address the multiple co-occurring medical and supportive service needs of older women with HIV. And that's all from me. I'd like to thank primarily our dedicated community-based interviewing team and all of the people with HIV who've shared their experiences with us over the past 3 decades. Thank you.